Okay, I am going to get the ball rolling here, everybody. Appreciate everyone having their mics on mute, and we're going to get started with today's National Fellow Online Lecture Series. Today's lecturer is Margot Putukian, and she's going to be talking about the sideline assessment of sports-related concussion. Margot, if you maybe advance the slide. Just as a reminder, this is an adjunct to your own programs, educational activities, and we're really just trying to provide an extra platform to allow our fellows and currently in fellowship and our AMSSM members at large access to guest speakers such as Dr. Putukian tonight, talking about a variety of topics. It was very successful last year. Our main priority is assisting in preparation for the CAQ exam for our current fellows. You can see a quick screenshot there of our subcommittee, all of whom have been very busy lining up speakers for you for the next several months. And really, without further ado, I want to introduce Dr. Putukian. She is currently the Chief Medical Officer for Major League Soccer. That was a position that she took recently, having served as the head team physician at Princeton University for 15 plus years. I think 2004, she just told me. So 17 years actually at Princeton. Dr. Putukian has been a very well-published member of AMSSM, often speaks at our national conferences on head injury and concussion, has published a number of her own research, particularly in soccer and lacrosse, and has contributed to a number of the consensus statements, for instance, the most recent AMSSM position statement regarding sports-related concussion. So probably one of the most knowledgeable people in the world here tonight to talk to us about sideline evaluation of sports-related concussion. I will be moderating. I'm Hamish Kerr. I'm the program director in Albany, New York, and I will be helping us to perhaps, if we have time, do some question and answer towards the end of the presentation, and perhaps even some CAQ prep questions if we have time at the end. So I'm going to hand over to Dr. Putukian, and I'm going to turn my mute on.
All right. Well, good evening, everybody. And thank you so much. I want to thank the Education Committee and the Fellowship Committee for the opportunity to present, and Hamish for providing the introduction. I do have some disclosures that are listed here, and basically just the views tonight are mine and not the organizations that I work with. So our primary objective is really what I want you to sort of come away with is the responsibility that you have on the sideline, and pay attention, recognize the mechanisms of injury as well as the observable signs of concussion, utilize a standardized approach to assess the athlete that has suspected concussion, and perform complete and thorough evaluations, including serial assessments. And if there's any suspicion for concussion, remove the athlete from play. And the outline for tonight, really I'm going to provide a little bit of a historical context as well as what I see are challenges for this injury. And then talk a little bit about sort of the action plan that you need to put in place in terms of being on the sideline, what you actually do on the sideline, as well as then some of the decision-making that has to occur, again, on the sideline. And the overall, take home is really have a plan, and a lot of these things will take care of themselves. So why is concussion so interesting to me? How did I get involved? And, when I was a fellow at Michigan State, my fellowship directors had an interest in concussion. And so I was assigned a topic to sort of review, and concussion was the topic. And at the time, there were a lot of the TOR guidelines, the CANTU guidelines, there were grading systems. And then when I started my first job at Penn State University, I was there for a little over a decade. I had really 2 or 3 really interesting cases early in my career there. that made me have a real interest in the topic and start some research and introduce me to Ruben Echemendia, who's a neuropsychologist who I have continued to work with. Again, you know, this is a topic that is still evolving. I'm still learning. And, you know, I was happy to be involved with the NATA's first NATA statement in 2004. And at the time, you know, if you did an evaluation, you had an athlete that had a concussion and their symptoms cleared, you would put them through some tests, you would put them through some, you know, exertional maneuvers, and then you'd put them back in the game and pat yourself on the back. So things have really changed quite a bit. And there have been a lot of statements since then, the team physician consensus statement, the pediatric statement, the first concussion in sport meeting that I attended was in 2008. That was the third one. Those occur every 4 years. The TPCC was updated in 2011. The AMSSM had their first statement that Dr. Harmon led the charge on. The NATA updated their statement, the AAN, American Academy of Neurology. And then the most recent guidelines, and there's plenty others that I haven't included here, but the most recent guidelines are the 2016 guidelines from the Concussion in Sport, the fifth international meeting. The AMSSM statement that Kim again led the charge on, that was really extremely well done in 2019. The NFL published their guidelines in 2019 as well. And then the most recent in the last few weeks is the team physician consensus statement that was published this year. I'm sorry about this. This is unavoidable. The British Journal of Sports Medicine. That's my dog. So the challenges for this injury, I think, are that it's elusive. There's no clear marker. There's a significant variability in the presentation, and the signs and symptoms of concussion may be delayed. In addition, there are limitations to what we can do on the sideline, and making that return to play decision can oftentimes be quite pressured. And we'll spend a lot more time talking about those this evening. Again, the sensitivity and specificity of the measures that we use, as well as understand that the return to play decision needs to be individualized based on the current injury, as well as that athlete's modifiers and or risk factors. And in some ways, this is part of the reason I have also always enjoyed taking care of this injury on the sideline, because it's really more art than science, and it really allows us to be physicians and take a good history and do a good exam. So in terms of pre-event planning, I think that there's a lot that goes on ahead of time. So instead of, you know, in the days when I was a fellow, you just showed up and you covered the game and there wasn't a lot of pre-event planning. And now, as I hope you will all learn, it's really important to have a plan, and in terms of the emergency action plan, include concussion for those sports that are high risk. It also includes education, and we'll talk a lot about that. The baseline exam that you might perform before the beginning of your season, the injury evaluation itself, as well as the information that you provide to the athlete when they are diagnosed with a concussion. In terms of the definition of concussion, again, most of the most recent guidelines all follow this concussion in sport group definition, which is really stating that concussion is primarily a clinical process that occurs as a result of trauma. It can be either direct blow or indirect blow that transmits forces to the head. And again, I won't go through all of this. I would hope that this will be one of the papers that you should review. And it is the definition that's used by the AMSSM statement, as well as the team physician consensus statement and the NFL statement. So again, the emergency action plan is not specific, right? Just in terms of concussion, but also should really cover other issues such as, you know, cervical spine injuries or other potential emergencies. And I don't know how many of you followed the Euros, but this is an injury that occurred during the Euros this summer. And imagine if you're on the sideline and you're you're on the opposite side of the field, and let's say you were, you know, looking at someone else and you didn't actually see what occurred, all you see is a player down, and when you get out there, he's unresponsive. This player ended up having a sudden cardiac event, a sudden cardiac arrest. And again, it's really important. You'll see the medical staff arrive really quickly. The first thing they do is get everybody out of the way and pay attention to the athlete. And again, they performed CPR and used an AED and saved this guy's life. But I think the things to pay attention to are, there's a lot of planning that goes in advance when you're going to be on the sideline. So education is really important. I started working on the NFL's Head, Neck, and Spine Committee in 2010, and one of the first tasks that our committee had was to create a poster, an educational poster, and it quickly was morphed by the CDC into one for youth. And there's a lot of education that's really important, and it's not just the athletes, right? It's also every other stakeholder, including coaches and parents, the medical staff and referees and the administrators, and a lot of the, this is the USSF, their take-home information. This is the NCAA's educational information for not only athletes, but also coaches. And I think that most of these all have in common the same things, really talking about signs and symptoms, why it's important to report symptoms right away, understanding that early recognition is associated with early recovery, and understanding that concussion is a brain injury. I'm gonna play some of this. This is from Thief Pro, and if you go to YouTube and you search Thief Pro concussion education, it's a short video.
Hello,
it's 4 minutes long.
I want to talk with you about concussions.
And what I like about it is it's a player.
Football,
Peter Cech is a goalkeeper.
We need to be
very had several injuries.
We only have one brain, and we need it for everything we do.
I won't run through all of it.
I have had my share of concussions and blows to the head, and it's simply horrific. Luckily, I've had people who look.
So I'm going to speed forward because they do show some mechanisms.
In a match 2 weeks ago, I connected with the ball. Then I didn't really know where I was. I was just staring at the sky. It was such a beautiful day. I felt weird. I really thought I was okay. I just wanted to get back into the game. Put me back in. I'm ready. I want to go back in. I didn't realise what had happened to me. Remember Pereira in this match in the 2014 World Cup? I know how that feels. All I wanted was to play. They told me I had concussion. It's a brain injury that affects your ability to function properly. I couldn't go back in the game. My clash was similar to Mascherano's collision in the 2014 World Cup. I had many symptoms of concussion. I didn't know where I was. I stumbled. My head really hurt. I didn't answer questions. Everything was a little bit blurry. I was slightly nauseous for the rest of the day. I just felt really off. I didn't get knocked out. The majority of concussed players don't lose consciousness. Like Kramer in the 2014 World Cup final. You don't always see concussion at first. I mean, Kramer played on for about 15 minutes. Later, he admitted not even remembering where he was that day. If you recognise symptoms of concussion in a teammate or opponent, report it immediately. It's dangerous to send players back in. It's just reckless. I couldn't make a safe decision in that moment. No way. I'm really grateful to my teammates and other players on the pitch. They saw it right away and called.
So again, I'm going to stop there just because it's a great video. I think it's helpful to have a player's perspective, especially when you're trying to educate players. You know, again, the other component of education is really providing a little bit of what your protocol is all about. And I think, again, when I first started with the NFL, part of the reason they wanted to have a standardized protocol was because the commissioner basically said, I want to make sure that the way that concussion is handled in New England is the same as it's handled in Seattle. And so having a protocol that you can use that everyone knows is the protocol is quite useful in terms of being able to evaluate things. And examples of this include sort of, either pocket cards or a game day checklist. And the pocket card provides really just the on-field assessment, part of the sport concussion assessment tool in 3 different languages. And it's just a handy thing for the medical staff to have with them. And then the same thing with the concussion game day checklist. This is from the NFL that was published. And again, it goes through sort of what the protocol is if a player is identified that might have signs or symptoms, what they do on the field, and then what they do off the field. The other component of the plan that's important to sort of address before you're on the sideline is actually your baseline evaluation. And this should include risk factors or modifiers related to concussion history, headache, ADHD or learning disability, and mental health issues. And all of these realize that only concussion history is really a risk factor for having another concussion. The rest of them are really considered modifiers where they are associated with athletes that might have persisting symptoms or longer duration of symptoms in terms of recovery. The other components of the sideline exam should sort of mirror what you're going to do on the field, which includes sort of assessment of symptoms, a cognitive evaluation, and some kind of a balance or postural assessment. And that doesn't mean that you can't do more. There are a lot of folks that include some of the vestibular oculomotor screens and do additional testing as part of their baseline. But in terms of sort of a bare minimum, this is what I think you should have. And again, as a team physician, I think one of the responsibilities that you need to have when you're on the sideline is the recognition and evaluation of an athlete with potential concussion. It's really one of the great responsibilities that we do have as a sideline physician. And again, be thorough, even if it's an obvious diagnosis, and we'll talk about this later, but that initial assessment that you perform can oftentimes provide you with some prognostic information. So even though the athlete has an obvious concussion, go through as much of the exam as you can because it can help prognosticate. And then finally, if there's an athlete that has a suspected or diagnosed concussion, even if their symptoms resolve, they don't go back in. And that's really something that's changed over the past few decades. Where to be on the sideline, I think it's important to stay vigilant and stay focused. We're returning the ball. I typically stand right at the line of scrimmage, and you'll see one of our players here, and he's lying motionless. And before the play is over, I'm actually running onto the field. My athletic trainers were in the tent, but they're at least two of them. But again, they always know that I'm going to be at the line of scrimmage, and that's typically where I stand so that I can pay attention to what goes on. And again, when you're on the sideline, it's really important that recognition is not just the responsibility of the medical staff, but then also, coaches, players, referees, they're all responsible for this. And it's really important to communicate. And again, if you're on the sideline, you can see these guys, 2 of them are watching the field and the other one is performing the evaluation. So a lot of times keeping your eyes on the field is really important, and communicating with other members of your team is going to be helpful as well. And then again, if you do have the additional resources, a lot of the professional leagues now have spotter programs and video review, and they're quite useful if they're available to you, and they just provide an extra set of eyes. This is a recent article that I think is extremely useful. We've used it to really change our protocol. And it was really performed by, it was a study in professional male athletes, primarily the NFL, the international hockey, Australian rules, rugby, cricket, I forget the others, but what they basically did was they looked at video signs of concussion, and found that there was a high likelihood of a diagnosis of concussion following a direct or indirect blow to the head with these 6 observable signs. And, lying motionless, motor incoordination, impact seizure, tonic posturing, falling without any protected action, and a blank vacant look. That German player in that video, educational video, Kramer, that blank vacant look was what he exhibited, and I'll show you some of the other signs. So this is an example of player that lying motionless. Medical staff goes on immediately. And when you see the video replay, you'll see that there is no protected action when he falls.
This is going to be a difficult one to watch because as Fernandez brings his foot up, I think Dijon's knocked out here. Oh, he's completely out. Oh, boy. Oh, boy.
It's always helpful when you have
completely unconscious
broadcasters that are.
So he watches right arm here. So many medical professionals and doctors will watch his right arm. He's got to come off. Absolutely, unequivocally needs to be off the field.
So that's an example of someone that's not able to brace themselves and then lying motionless. Here's another one.
Getting up. Now it's George Smith. He ran into Hibbert, and George Smith is out cold. It's not the way it was supposed to end for George Smith. My goodness, he took a terrible blow there.
Head to head, nothing wrong, nothing wrong.
Big head clash. George Smith, Richard Hibbert.
I will say that this is, I don't know exactly, I'm not up on rugby. Someone might be able to put in the chat when this is from. I believe it's from around 2010. So it's definitely outdated. They don't follow the same rules now that they did then.
Fortunate there for George Smith.
Yeah, Georgie's an extremely tough player. They're battling to get him up here. Whether he stays in the field or if he goes off, he is going to be.
Let's see, as he walks off, you can see that he's obviously struggling
to get over the collision. It's 4.5, but it's gone. Wonderful replacement. And like the loop with George Smith.
So 4.5 minutes gone.
Undergo some tests. Captain the Wallaby 6 times, 2007 to 2000. She was very surprised that George Smith comes back on the field. He can hardly stand up, hardly walk. George Smith has actually come back to the sideline. Looks like he's coming back on the.
So things have changed, fortunately, and we don't put players back in after that kind of an injury. There are additional observable signs. This is the paper I was referring to. And they occur frequently, but they do not have the same predictive ability in terms of diagnosing concussion. And again, we see these mechanisms quite frequently where an athlete is slow to get up or clutching their head or falling to the ground or bleeding, but they don't have the same predictive ability as the ones that the other observable signs. And this is just to show you in another sport, again, the same mechanism. You'll see the defender actually right here causes his own injury by going headfirst into a player and slow to get up, tries to get up and can't. And in the sport of lacrosse, guys routinely will get up as quick as possible. You don't ever want to show your opponent that you've been hurt, especially when you caused it. And he had a concussion. And then lastly, in another example in American football, and this was prior to the defenseless receiver rule. So then this again is not a recent video.
Where is into the dime. Where with a block. Time for Smith. Oh, and he's got Macklin at the 10. Flag.
And I'm going to speed this one up a little bit just to show it. And again, and what
with the
I think's interesting in this is when you see it again in slow motion, you see again that he also does not protect himself when he falls, just for a split second.
Smith has plenty of time. He's able to fit this one into a really tight window between the corner and the safeties.
Lowry got him beat out of 2.
So you can see him again try to kind of fall and not be responsive. I think the other thing in that particular one is, you know, that obviously that defender launched himself and it was a head-to-head hit. So in today's game, he would be removed from the game. So again, the necessary pieces of the sideline evaluation are literally the ABCs and in that order, because you are worried about the airway, and then ruling out cervical spine or skull fracture, spine boarding if necessary, and if not, if there's any kind of a concern for concussion, remember to have them observed and perform serial assessments. And this is just showing you what tonic posturing looks like, or fencing. And if you go to this website here, you can see a 4-minute video of several different sports and this tonic posturing behavior. So again, the most frequent symptoms that we see after concussion are listed here, probably not unfamiliar to all of you guys. And know that these are endorsed by 60 to 80% of individuals. But the problem with relying on these symptoms is, as we all know, it's subjective and they're not all specific to concussion. The cognitive exam, again, has limits, especially since when we talk about what's been performed on the sideline, there's what's called the ceiling effect. And we'll talk more about that. And obviously time constraints. So you're under pressure and you're trying to get an evaluation done with coach and others sort of wanting to know whether or not the player can come out or can stay in. And then finally balance, which oftentimes is helpful for that player, for like George Smith. It's been shown to be very useful as part of your assessment, but there are practice effects and concerns related to reliability. So again, to sort of bring you back, this is what, Mike McRae has done a tremendous amount of work in this area. And this is a really early data. He developed the SAC, the Standardized Assessment of Concussion, in 2000. And that included standard orientation questions, month, date, day, time, providing a list of 5 words 3 times, concentration, where he did digit span backwards, and then additional concentration, providing the months backwards, and then finally a delayed recall. And if you think about it, trying to remember 5 words, it's not that hard. And so there is what's called the ceiling effect, where pretty easy, people can max out and score really well on this particular exam. However, in his early work, he showed that there was a decline in the SAC, and it was able to differentiate injured versus uninjured with a sensitivity of 95%. But the take home really from it, though, is that after 48 hours, it's useless, right? So it's really good right away, but it's not good if you're delayed and sort of doing this in the office, or if there's a more than 48 hour of a delay. So remember that, because we'll talk about that later in the talk. Mike, along with Kevin Guskowitz, again, they've done just most incredible amount of work in this space. And this was some of their early work, again, looking at symptoms, looking at the cognitive function using the SAC, and then also postural stability, and pretty much showing us the typical recovery curves that occur. Let's talk about the SCAT. Now, the SCAT was developed by the Concussion and Sport Group, and it was actually the first SCAT was performed during the second Concussion and Sport Group meeting. And initially it was pretty much combining these separate measures of the checklist, a cognitive status, and the gross neurologic function, and putting it on a 2-page card. It was modified in 2008 during the third Concussion and Sport Group meeting, and they introduced a scoring system, and they had 8 subscales. And for those of the folks that on the listening in that are not fellows or were trained during this period of time, it was quite onerous because the scoring system was a pain. It was really a challenge to work with. And it was 4 pages long, but it basically incorporated the symptom checklist. It looked at physical signs. It had the SAC. It had the Maddox questions, which we'll explain. And then it had the balance error scoring system that Dr. Guskowitz created at UNC, the Glasgow Coma scale, and a coordination exam. Then in 2012, the SCAT-2 was revised to the SCAT-3. It's very similar. There weren't a lot of changes made, and it remained 4 pages long. And there really weren't, the SCAT-2 and the SCAT-3 are almost identical. What they did do is, number one, got rid of the scoring because it was the biggest complaint that everybody had. And then secondly, added some additional information about emergency management, started talking about these potential observable signs, and then provided some additional information and advice. And then finally, the most recent concussion and sport meeting in Berlin. This was published in 2017. There was a paper on the SCAT, and there were 2 really important systematic reviews that occurred with the main document. And each time, I think there were about 10 or 11 additional systematic reviews on various topics that are quite rigorous. And there were 2 on this particular, on the topic of sideline assessment, as well as improving the SCAT. Now, there's been a ton of literature. And again, this is just some of the articles that have looked at the SCAT and other sideline assessments. And we'll kind of go through some of them, but not all. The systematic review that John Patricius was the lead author on really was looking at what are the critical elements of the sideline assessment. And you know, some of the conclusions were that evidence-based recommendation for any single screening test or protocol is not possible. The recognition of suspected concussion is really best tackled using a multimodal approach, and that the SCAT currently represents the most well-established and rigorously developed instrument. The other systematic review that was done as part of the Berlin meeting was how to improve the SCAT-3. So how to make improvements as it relates to the actual tool. And so in doing this, we basically had to review any of the studies that had kind of sideline assessments. And yeah, I can't remember the numbers exactly, but there were thousands of articles, and we end up with like 30. Right, because there's bias, or there are other reasons why they're excluded, and you end up having really only the best articles that you're reviewing. And the conclusions from this paper were that the graded symptom checklist, the SAC and the BESS, were most useful immediately post-injury in being able to differentiate concussed versus non-concussed, but less effective after 3 to 5 days. The graded symptom checklist is useful in tracking recovery. Observable signs holds promise. And they noted that a limiting factor for the SCAT is evidence for the ceiling effect in the SAC, especially that immediate recall, those remembering just five words. So the modifications were the following. One is that the SCAT can't be completed in less than 10 minutes. It was broken down to immediate acute assessment and then an off-field assessment. And the acute on-field assessment was really looking for emergency management and observable signs. The symptom checklist should be completed when the athlete's in a resting state. That there should be an option of 10 words for the SAC, and that the delayed recall should occur no sooner than 5 minutes after the immediate recall. They added back the neurological screen. So again, in the very first SCAT, there was a neurological exam. It was removed and it was added back in for the SCAT-5. There was affirmation that the 5 should be supervised by a healthcare professional. They enhanced instruction. They added this period of rest immediately for 24 to 48 hours, and then exercise, as we all know from Dr. Letty's work. They added a return to school progression for return to learn, and indicated that a written clearance should be provided as well prior to return to play. And again, there's also a child SCAT-5, and you notice that we skipped SCAT-4, and it was just such that the 5th concussion sport group meeting actually was consistent with the 5th SCAT. So that was just a matter of making it easier, and now it's 8 pages. But understand that many of there's a lot of instruction. If you go to the SCAT, there's a lot of instruction and information in there that it's felt to be quite useful. So we'll run through this, and again, I think that it's useful to sort of have an organized approach. As I mentioned, there are sort of 2 steps: the on-field assessment, where you're just talking about red flags, observable signs, thematics, Glasgow Coma scale, and a cervical spine assessment. And if there's any question that there is a suspected concussion, then the off-field assessment should be performed in a distraction-free environment, ideally with the athlete in a resting state. And the off-field assessment includes getting more information about their background in terms of prior history of injury, doing a symptom evaluation, doing the Caq, as well as a neurological screen that includes the modified balance error scoring system, delayed recall, and then making a decision. In terms of an immediate assessment, this is where you're sort of looking for the red flags, right, in the setting of head trauma, and those observable signs that we've already mentioned. You'll notice that the facial injury after head trauma is different, and it's, you know, again, the Davis article was just published in 2019, but I think many of us have taken sort of that Davis article and incorporated them into our Gameday checklist just to keep it current. The Glasgow Coma scale and the Maddox, and then the cervical spine assessment. And these are the red flags. Again, if you have an athlete where they lose consciousness, or they're having seizures, if they're getting worse instead of better, if their headache's getting worse or severe, if they have you know, changes in their mental status, so if they're becoming restless or agitated, I think those are some of the red flags that you should really consider transporting them to a medical facility. And again, listen to your gut. These are times where we had a situation at Princeton back in 2012 where I just happened to be at practice at the end of it, and was asked to evaluate a player who had a headache. And as I went through the evaluation and tried to ask him questions about, you know, where we were, what game we had played, it was clear that he had was having trouble. He was struggling. And I went from sort of saying, all right, you know, probably need to get a CAT scan. His headache's getting much worse. Probably need to, you know, send him via public safety over to the hospital, to no, he's going to go by ambulance. And then he got a lot worse. And I was like, not only is he going by ambulance, but he's going to a neurotrauma center. And I've done that twice in the 17 years I was at Princeton, and he ended up having an AVM that bled. So listen to your gut, because sometimes it's spot on. So again, the on-field assessment includes the Glasgow Coma scale, and this shows again that tonic posturing, as well as then this player ends up having seizure activity. This player is also hurt, as he's pointing out. And again, the cervical spine assessment is really, you know, if the player is awake and conscious, asking them if they have neck pain, asking them if they have any neck tenderness, and then certainly if they are not lucid or fully conscious, then you should assume that they have a cervical spine injury. In this particular scenario, I'll wait till they show the replay, and you can see again the typical scenario in soccer, sort of going for aerial challenge and a head-to-head blow. Kane gets out of the way, and those guys collide heads. And in the end, that player that was seizing it had a fracture of his skull, and the player that came off and got sutured ended up being removed later with a concussion. So the Maddox questions, which were developed by Brian Maddox, is worked in the field of in rugby, and those questions are more useful than the traditional orientation questions, but they include, you know, what venue are we at, what half is it, who just scored, who we played last week, and did we win? And again, for any of you that are right now in preseason, it's hard to remember the date or the day. So these are actually a lot more useful. The off-field evaluation, again, it's getting more information about the athlete, giving the athlete the symptom checklist and asking them to actually read through the symptoms. and making sure that they can actually read. That's part of the neurologic exam. And then going through the SAC, which includes the standard orientation questions. And again, if you take anything from this talk tonight, it would be that unless you're dealing with little kids, where 5 words might be enough, really, I would urge you to use 10 words. I just think that it's such an improvement in terms of the tool. 3 trials, and then months backwards, and then digit span backwards, and then at least 5 minutes later going through and asking them to provide the words that you gave them previously. And then finally, a neurological screen that includes balance, but it is their ability to read, their full motion of their cervical spine, the ability to look side to side, up and down without having double vision, finger to nose, tandem gait, and the modified BESS. And again, this was developed by the balance error scoring system was developed by Kevin Guskowitz at UNC, and has been validated. It's quite useful. And then finally, you know, this is really not necessary for this talk this evening, but again, it's really important to try to make a decision as to whether or not the athlete has a concussion. But please remember, the second take home would be that you can't rely on any kind of a sideline measure, no matter what it is, as a standalone tool. It can't be used to measure recovery or make decisions about an athlete's ability to return to play. And you know, you can have an athlete score perfectly or better than their baseline on this and still have a concussion. So again, you have to listen to your clinical judgment. The SCAT again provides some additional information, and at Princeton we had a separate sort of take-home sheet that we gave to athletes that provided some of the same information. But again, it's sort of, you know, telling them to avoid alcohol, telling them to avoid medications, don't drive unless they've been cleared by a healthcare provider. What to watch for if in case they need to go to the hospital later, you know, if there is sort of they end up having vomiting, worsening headache, then you know you want to be able to provide them with what to do if those things occur, and then also ability. I think most athletes want to know when they're going to be able to return, and even though they may not pay attention to your season talk about concussion, when they've been concussed, they then pay attention to sort of how quickly they can get back. And even though in their concussed state, they're not going to be able to decipher much of this, if you provide it to them, they can read it later, or you provide it to their family, and they can be aware of sort of what the return to sport and the return to school strategies are. You know, we did some work looking at the SCAT. This was back in 2015, and we looked at baseline and post-injury SCAT performance on concussed versus control athletes. And we had a variety of sports, and we had 32 diagnosed with concussion and compared them to controls. And for every measure, we looked at symptoms, the SAC, and the BESS from the SCAT-2, and basically every measure was statistically significant in showing a difference in terms of being able to differentiate concussed versus non-concussed. The SAC, actually, that was a 5-word SAC, sorry. Actually, the concussed athletes scored the same that they did baseline, but our controls scored better. And again, there's such a ceiling effect with that particular test that was in and of itself, it was statistically significant. What we actually were able to show is if you compared the score and, you know, again, combining the entire score and compared it to their baseline, that the SCAT actually had a sensitivity of 96% and a specificity of 81%. And then if you didn't compare it to a baseline, but instead used a cutoff score, it was scored to 100. That again, it performed quite well in our experience. There's been additional work that's looked at the SCAT and how it's performed. And again, by and large, all of these studies that look at concussion, no matter what sideline test you use, symptoms really have the largest effect. And they also are useful in terms of looking at recovery. So as opposed to the other components of the sideline assessments. Symptom checklist is actually quite useful. This particular study by Chin that looked at high school and collegiate athletes did also see an effect size for the SAC and the BEST. They're small to moderate at, again, early, and they were insignificant by day 8. And there was again, symptoms were better than cognitive imbalance in terms of the area under the curve and in terms of being able to differentiate concussed versus non-concussed. This is a study in collegiate athletes, and again, controls. They had their evaluation at baseline, 3 to 5 days after injury, and then 3 weeks post-injury. Again, symptoms are really helpful, but the SAC and the BEST weren't so good. And when you compared to their normative data, there was no difference. But the limitations really are this post-injury assessment was done at 3 to 5 days after injury, which is when we already know that it's not going to be very useful, right? So again, that's some of the issues with some of the literature when you look at it critically. And then another study looking at the SCAT3 in university athletes. And again, they were assessed within 48 hours. They did show that the symptoms and the symptom severity score was definitely quite useful. They did also show statistically significant differences in the SAC and orientation, delayed recall, the BEST, tandem gait, but they weren't significant when you looked at median scores. And when you looked in terms of, only 50% showed a decline in their SAC and their delayed recall, their BEST, and their tandem gait. So their conclusion was that wasn't so great, but again, there's certainly some limitations. In this particular article, only 32% of them did not have their SCAT performed on the same day. So again, it's really, I think it's limiting. And they also don't have control. So when you don't see that practice effect, you don't see athletes performing better, it might mean that there is a significant change. Finally, more recently, this is data that comes from the NCAA and the DOD. And they looked at select assessments at the within 6 hours, at the 24 to 48 hours, and compared them to baseline as well as the unrestricted return to play. Again, symptoms have the highest combination of sensitivity, specificity, and areas under the curve. But the full model that incorporated the SAC and the postural assessment had really the highest sensitivity, specificity, and area under the curve, and outperformed all of the univariate raw score and objective models. So again, I think this is probably the best data that looks at a large sample of collegiate athletes in the military and demonstrates that a multimodal approach is quite useful. And then, let's talk a little bit about this 10-word list. And again, this is a study that compared the performance on the SCAT3 and the SCAT5 administered pre-season. And what they found was that no participant scored perfect on the 30 immediate, like the 3 trials of 10, the 3 trials of 10 words. No individual scored perfectly, and only 5% scored perfectly on the delayed recall for the 10-word list, compared to 60% scoring perfectly on the 5-word immediate recall, and 40% scoring a perfect 5 on the delayed recall for the 5-word list. Again, this is pretty powerful, and you can see this is how athletes perform on that first trial, then the second trial, and then the third trial. They're getting better. And when you look at, again, the bottom shows you their performance on the immediate memory for the 5-word list and the SCAT3, and then their delayed memory. And you can see that there's a ceiling effect, right? Pretty easily, most athletes are able to sort of max this out and perform perfectly on this test, compared to the 10-word recall, where you see this bell-shaped curve, where there's an opportunity to then better discriminate an athlete that may be struggling with their immediate and their delayed recall. Now, again, this was just baseline performance. We actually have some data that's not yet been published related to performance post-injury, but I'm not sure we'll get that out, but hopefully we will. So there are additional tools that many of you may have, may be using and are potentially going to be part of the SCAT-6 if I can predict. This ocular motor and vestibular, the VOMs and sort of some of the screening that's out there, I think has shown a lot of good research recently related to, looking at tracking, and there's so many concussions do include the ocular system and the vestibular system. The King-Devic, which is unfortunately not a free test, but is an eye tracking test. I included Kim's paper here because she looked at a lot of, this is very recent, and their group looked at a lot of the Sideline tests that have been used and found that the King-Devic was reasonable. The symptoms score was actually the best predictor, as again, not surprising. And she did review in this the SCAT, but it's divided in its subcomponents. And again, none of the studies in that particular paper used a 10-word list. And then a shout out to Dr. Master. Tina has a great video for if you want to sort of see the eye exams, especially in the pediatric population. I would refer you to this great video. There are additional tools out there that haven't really gained much traction. Quantitative EEG has been out for a while. Some of the imaging studies, functional MRI, MRS, susceptibility weighted imaging, diffusion tensor imaging, functional near infrared spectroscopy is relatively new. But in speaking with some of the folks that are very much involved with some of these, it's challenging certainly to apply them across the board, and certainly on a Sideline. The quantitative EEG, in talking with Mike McCrae, is close but not quite ready for prime time, according to him. And then the other thing that's been taken sort of a lot of attention recently, and I'm really interested to see what comes of it, are the salivary micro RNAs. Again, there's some folks at Penn State and then Simon and his group in rugby have been looking at this. And again, in talking with Dr. Kemp, he's hopeful that there'll be some work on the horizon in this regard. So some take-home points. Again, the concussion and sport group process every 4 years, every 5th year now. Very rigorous systematic review of the literature, and so stay tuned for what comes in that regard as it relates to an update of the Sideline assessment. The SCAT is multimodal, a standardized assessment that has good sensitivity and specificity, especially when it's used immediately post-injury. So again, on the Sideline, symptoms remain the most powerful indicator of not only acute injury, but then also recovery. And I think that increasing the word list from 5 to 10 will make a significant difference. And then additional domains that may add clinical utility include maybe clinical reaction time, these video observable signs, and oculomotor screening. I'm going to bring you back to the NFL Gameday Checklist. Again, this was published by the protocol has been published, and this concussion Gameday Checklist is involved in it. And again, it really goes through the idea of sort of looking for these no-goes, doing a Sideline on-field assessment, looking for the cervical spine issues and observing gait, doing a focused neurologic exam, and then bringing them off the field if there's any concern for injury, and doing the rest of the NFL's modified SCAT. We have the same thing with MLS, and I know that the NHL does the same thing as well in terms of a modified SCAT. A lot of times on the Sideline, you're going to get asked this question, usually by the coach, how bad is it? Or sometimes the player, how severe is it? How long will they be out? And unfortunately, this is an injury where, as of yet, we're still unable to determine that until their symptoms have cleared and their neurologic exam and their cognitive evaluation is back to normal. It again underscores the importance of doing as complete an evaluation as you can during that initial assessment on the sideline. And realize that the nature, the burden, and the duration of the symptoms are probably more indicative of severity of injury. And don't miss the two extremes. I think I mentioned this previously, but the athlete that can pass that sideline test and yet still have a significant injury. Again, that's a disadvantage of having a brief evaluation, especially if the athlete says they're fine. And also at the advantage of knowing your athlete. Sometimes you just know that they're not right, and listen to that because that's where the clinical part of this takes place. And then again, the athlete with more serious brain injury, and again that this shows the athlete falling unprotected and lying motionless, and then when he gets up, stumbling, and he ended up having a skull fracture. Again, providing the athlete with some information, I think it's useful for them to get this because they inevitably weren't listening when you gave it to them the first time, telling them that in an adult, it can take 7 to 10 days to 14 for concussions to completely resolve, and that's the typical time frame for an adult. For kids, it's a little bit longer, and that again, we're getting them back to being active as soon as a couple of days go by and they're not aggravated by being active. We are trying to get them back into non-contact activity because we know exercise is good for the brain. But remember that this decision is individualized, and there are a lot of factors that have to be considered when you make this decision. And as Stan Herring taught me, if you've seen one concussion, you've seen one concussion. I think they're all different. There are some barriers related to the injury that I think we've talked about. There are obvious signs are not always present, and sometimes symptoms can take minutes to hours to even a couple of days to develop. We don't yet have a true biomarker to tell us whether someone actually has an injury. We have to rely on signs and symptoms that we know are not specific to concussion. And there are a lot of other things that present very similarly and have the same kinds of symptoms. There are also barriers related to the sport. Again, the size of the field. Sometimes players are really far away and it's hard to see. Sometimes you don't have stoppage time during a game. Medical staff may not be there and may not be available for different sports or for different reasons. And for some sports, the substitution rules at elite levels of play don't allow you to have a substitute. So some take-home messages: the sideline evaluation of possible concussion is a really important responsibility for the team physician. It's a clinical diagnosis. Look for the mechanism of injury as well as signs and symptoms. Be thorough. And any athlete that has any suspected concussion should be removed from play, even if their symptoms resolve. And remember to review the emergency action plan and take a medical timeout. So I'm hoping we have time for 2 questions. These are the Caq Prep questions. One is the first one. I don't know, Hamish, if you want me to run through these. I'm assuming you do. You're covering a collegiate women's soccer match. A challenge for the lob ball ends with a player from the side you're covering taking an elbow to the head. No loss of consciousness, but she struggles with her balance, answering questions about where she is, has blurry vision and a headache. She's pulled from the game and diagnosed with a concussion. When you reevaluate her on the sideline, which of the following would be concerning for a more severe injury requiring further evaluation? And your options are listed. And I'm assuming we just wait a few minutes till you guys come up with what your answers might be. And the answer is A, increased agitation and unusual behavior. So again, all these other symptoms may develop and they should be monitored. But the one that was listed as a red flag is this increased agitation or unusual behavior. So certainly that, and the other ones that are really probably the most common red flags are someone that's lost consciousness for more than a couple seconds, or for that headache that's getting worse instead of better. So if someone's symptoms are getting worse instead of better, I'm pretty uncomfortable.
Margot, maybe we should just pause there for any other questions from the audience.
Okay.
I want to thank you. That was a fantastic run through of Sideline Evaluation of Concussion, and it's just really great prep for everyone that's going to be covering games potentially this weekend. I particularly like the video. I think all of us really kind of learn best from seeing things, and watching those videos was fantastic. I liked the video best of the MLS game with Taylor Twellman commentating, because even Taylor was able to notice that someone was knocked unconscious. So well done, Taylor Twellman. But in all honesty, loss of consciousness is often very brief, I'm sure you'd agree, and can be very challenging to recognize without going back to watch the video. So just you should be aware of that it's not always as obvious as we're showing in the highlight reels here. Yeah,
exactly. No, I think it's a good point. In fact, the one of the American football player, I think, also was useful, because I think that one shows that you have players that are, for a brief moment, he's not controlling himself. He's not bracing himself. And I think, again, that's the power of video, which I know isn't always available, but it's why it's so important on the sideline to be vigilant, pay attention, and, that part of the responsibility is important.
Fantastic. And I think, your run through of all the kind of components of the SCAT and what is important and what's perhaps still building evidence is, I think, really well described in the last AMSSM position standing concussion. I think there's a whole table that kind of documents the components of the SCAT. So is there anything that you anticipate in SCAT 6?
Yeah, it's a good question. I do think that, having been one of the reviewers for the abstracts, there are a lot of abstracts that were dealing with the vestibulo-ocular, and I think that probably has some credence, and the reaction time measures. I mean, it is interesting, but and it was pretty close last time. I mean, we were really unsure, but you're trying to figure out a way to make something better. And is there something is there value added to a tool, and without making it become so onerous time-wise, right? Because that's the other piece of it. And the other thing that I think is going to occur is, and John Patricius has published on this, is the SCOAT, the office assessment tool. And that may be the other piece that I think they're going to build on, in terms of having an office tool that might be more useful, since a lot of these concussions aren't seen right away on the sideline, and sometimes they're seen in the office a day or so later. So if we had a better office tool, I mean, because how many of us use the SCAT in the office the first time you're seeing an athlete, and if you're 3 days later, and we already know that it's not a very good tool. I mean, making it a 10-word list, I think, is quite useful.
That builds on one of the questions from a fellow at the Detroit Fellowship Program. Roy asked what we should do in the office, and are serial exams beneficial? And I think one of the things I've learned with working in rugby is that you can't hang your hat on that initial sideline assessment. You've really got to do a follow-up after the game and perhaps the following day. But what that should be, that office and training room assessment, probably varies.
Yeah, I think it is. And honestly, a lot of times I have, started in the office setting, was doing the VOMs. I think it's challenging, because sometimes when you're seeing someone acutely, or even a day later or 3 days later, they're still really symptomatic. And sometimes it's really challenging to do some of those maneuvers. And then asking them symptoms every day, at a certain point in time, you got to stop, right? Like, you don't want to be asking someone a symptom checklist, endlessly every day for 3 weeks on end, right? So at a certain point, you might do that initially, where you're asking them about symptoms and repeating parts of that exam. But otherwise, it's really a matter of, sort of tracking their symptoms. And sometimes some of the, if you do near point convergence and it's markedly abnormal, I've been impressed with sort of seeing how that changes, because that is something that all of a sudden I might repeat that again and say, oh, geez, wow, that got a lot better, right? But you know, again, it depends on what you're using in your office setting. At Princeton, we were using, you know, a hybrid battery of computerized and paper pencil neuropsychological testing. So that's what we used as our, you know, when we would do that at within 48 hours, and then we'd repeat it if we needed to. And again, we did that initially just to sort of prognosticate, but then also it helped us in terms of being able to evaluate their cognitive function. And then repeating the balance assessment is the other piece, because otherwise you're doing the symptoms, and then we were doing the neuropsych testing and for the cognitive piece. And so the only part that I would repeat would be the components that might be abnormal, or repeating the balance prior to letting them back into full play.
Yeah, I have a similar approach with balance and the cognitive assessments. And, you know, I think one last point to highlight was you mentioned a couple of times, you know, case presentations where it was more than a concussion. It was a brain bleed with an AVM.
Yeah.
And then even the FIFA video with Peter Caq. I mean, Peter Caq fractured his skull. It was not just a concussion. It was a really serious injury. I remember watching it. And that, I mean, when we're on the sidelines, that's really what we're trying to recognize is the more serious injuries than concussions sometimes. I think we have to remember that, you know, you can have an athlete deteriorate on you as you described at Princeton. I mean, I think that's alarming to all of us to hear someone going downhill that fast. So good to point out.
Yeah, that was really scary, to be quite honest with you, because I literally was at the end of football practice, and I was on my way to the soccer game. And so I literally brought the player off, and initially was, you know, call public safety and we'll send him over. And then he started to, he said, I need to find the bathroom. I'm going to throw up. And he started vomiting. He got lethargic, and I was like, forget, call an ambulance. And then by the time the ambulance, literally within minutes, I was like, forget the, you know, we're going to the neurotrauma center. And they packaged him up. I said, is it all right for me to call your dad? He goes, yeah. And I went out to my car, and as I'm going out to my car, the rig is pulled on the side of the road. And I go to the back of it, and I knock on the window, and I'm like, why are you still here? And the EMT said, well, we're just trying to figure out why we're not sending him just to the local hospital. And I said, listen, I'm the physician. He's worse. Send him to the trauma center. And again, I've done that twice in my 17-year career. And literally I called the dad, and then within minutes, the resident called me from the hospital saying that he had a AVM that bled, and they put a burr hole in. And for the longest time, it really was, it scared me, because I was like, I wasn't even sure why. I wasn't sure why, if that makes any sense, you know. And I remember my athletic trainer saying, oh my gosh, I'm glad you were at practice, because we would have sent them to the local hospital.
Go with your gut, I guess, just like you said.
Gut. You're never going to be faulted. I mean, you know what, if you end up going with your gut and you're too, you know, conservative, you know, they're so, you know, so be it. But I think, you know. Well,
Dr. Putukian, final thank you from everyone on the call tonight. We've really enjoyed listening to your clinical experience and research, and I really appreciate you taking the time to talk to us. Thanks.
Thank you very much. Thanks for everyone's patience.